Welcome to the Explainer. All right, if you're studying pathology, you know you're going to get questions on the thyroid nodule. I mean, it's one of the most common things we see in the clinic, and it's a total classic for exams. So today, we're going to walk through the whole diagnostic journey, step by step, so you can absolutely nail your answer. So here's our game plan. We'll kick things off right where the case begins, with that first investigation of a nodule. Then we're going to decode the pathologist's secret language, the Bethesda system. After that, we'll tackle the infamous follicular dilemma and lock in the key features of the big cancers. We'll even cover the really nasty ones before we wrap it all up with that perfect, polished answer for your oral exams. So let's jump in.
Okay, so our story always starts in the same place, with a patient. And in this case, it's a patient who has a thyroid nodule. Maybe they felt it, or maybe it was just found by accident on a scan. Right? So a patient has a nodule. The first thing on everyone's mind is this cancer? But the first step actually isn't a biopsy. Before we even think about a needle, the whole workup begins with imaging to figure out the risk. This is the standard playbook right here. It all starts with an ultrasound. Radiologists are looking for suspicious features, things like weird margins or tiny calcifications, and they use that to give it a TRAD score. You can think of this score as a gatekeeper. If and only if the TRAD score is high enough, does it trigger the next step, the fine needle aspiration, or FNA, which finally gets us the cells we need to look at. So now we've got our cells, and this is where it gets really interesting. We don't just spit out a simple benign or malignant, we use this standardized framework called the Bethesda system. It's basically a roadmap for the clinician that tells them exactly what to do next for the patient. And here it is. The Bethesda system is this 6-category framework that directly links what we see on the slide to the actual risk of cancer. On the low end, you've got categories I and II, which basically mean we either need another sample or the patient can breathe easy because it's benign. On the high end, category 6 means it's cancer, and surgery is pretty much a sure thing. But the real headache is right in the middle. This right here, this is the most critical part of the whole system. These indeterminate categories. This is the pathologist's gray zone. When we sign out a case as atypia of undetermined significance or a follicular neoplasm, we're pretty much saying, look, these cells are not quite right, but I can't definitively call them cancer, not based on this smear alone. And it's that uncertainty that pushes the case to the next step, which is often molecular testing or even diagnostic surgery. So let's really dive into that gray area, and let's focus on the biggest challenge in Bethesda Category 4, the follicular neoplasm. This is what we call the follicular dilemma. And this is the core of that dilemma. On a smear from an FNA, a benign follicular adenoma and a malignant follicular carcinoma can look, identical. You've got the same crowded, uniform-looking follicular cells. The only way to tell them apart is to have the entire nodule surgically removed, so we can search for the one thing that defines cancer here, invasion. We physically have to see tumor cells busting through the capsule or getting into blood vessels. If you don't see that, you cannot call it carcinoma, period. Now, here's a super important concept for your exams, NIFTA. It stands for non-invasive follicular thyroid neoplasm with papillary-like nuclear features. It's a mouthful, I know, but the idea is actually pretty straightforward. It looks a lot like a type of papillary cancer, but it's totally encapsulated, and, this is the key, it's non-invasive. For a long time, we called this cancer, but then we realized these patients do incredibly well. So to keep people from getting unnecessary surgeries or radioactive iodine, the entire field basically downgraded it to a low-risk neoplasm. This chart is just fantastic because it connects what things look like to the molecular drivers behind them. Let's walk through it. See the tumors that grow in that follicular pattern? A lot of them are driven by RAS mutations. If the nuclei look pretty normal, you get a follicular adenoma or carcinoma. But if those same RAS-mutated cells start to get those papillary-like nuclear features, now you're heading down the path to a NIFTP or an invasive follicular variant of PTC. And then in total contrast, you have classic papillary carcinoma with its true finger-like growth, which is almost always driven by a BRAF mutation. This molecular split is a huge concept in thyroid path. Okay, let's switch gears and focus on that classic cancer now. The most common one you'll ever see, papillary thyroid carcinoma, and its totally unforgettable features under the microscope.
So, papillary carcinoma is number one, the most common thyroid cancer, but the good news is it has a fantastic prognosis. The diagnosis is all about the nucleus. Yeah, you might see those finger-like papillary structures, but you don't actually have to. What's completely non-negotiable are the nuclear features you see here. The chromatin clearing that makes them look empty, those nuclear grooves that kind of look like coffee beans, and pseudo-inclusions. And hey, if you happen to spot these little layered calcifications called psammoma bodies, that's another huge clue you're on the right track.
And if you remember just one thing about PTC for your exams, please make it this phrase. The chromatin inside the nucleus gets super fine and gets pushed out to the edges, making the center look all clear and empty, just like the eyes of that old comic strip character, Little Orphan Annie. It's a pathognomonic feature, you gotta know it.
So far, we've talked about tumors with really good outcomes. But we have to change our tune now because it is absolutely critical that you can recognize the other end of this spectrum, the aggressive and often deadly thyroid cancers.
These three represent a whole spectrum of danger. Poorly differentiated carcinoma is sort of the bridge. It's more aggressive than PTC, but not nearly as bad as anaplastic. Anaplastic carcinoma, though, is a true monster. It's undifferentiated, it grows like crazy, and the prognosis is just awful. And then you have medullary carcinoma, which is a completely different beast altogether. It doesn't even come from the follicular cells. It comes from the C cells that make calcitonin.
So, when the histology is a bit of a mess, how do we know for sure where the tumor came from? Well, we use immunohistochemistry. These are stains that are like molecular highlighters. All the follicular-derived tumors, from the benign ones to PTC, will stain positive for thyroglobulin. Medullary carcinoma, on the other hand, will be totally negative for thyroglobulin, but will light up like a Christmas tree for calcitonin. That calcitonin stain is the absolute proof of its C-cell origin.
Okay, we've hit all the major players. Now for the most important part. How do you pull all this together into that clear, concise, and really impressive answer that your professor wants to hear in an oral exam?
Just think of this as a quick practice run. Based on everything we've just talked about, let's go through some of the highest yield questions that you're almost guaranteed to see pop up. You can see how these questions hit all the key decision points, right? The adenoma versus carcinoma question tests if you get the whole concept of invasion. The PTC question tests your classic morphology. The IHC question tests if you can tell different tumors apart and link them to clinical stuff like MEN2 for medullary carcinoma. And the NIFT question? That just makes sure you're up to date on how we classify these things now. All right, here it is, your polished summary answer. You'd say something like, okay, so when we evaluate a thyroid nodule, the workup starts with an ultrasound to stratify risk, which is then followed by an FNA. We classify that cytology using the Bethesda system. The real diagnostic challenge is telling a follicular adenoma from a carcinoma, which absolutely requires finding capsular or vascular invasion on the surgical specimen. The most common cancer, papillary carcinoma, is defined by its classic nuclear features like orphan Annie eyes and grooves. And finally, it's critical to distinguish these follicular-derived tumors from medullary carcinoma, which comes from C cells and is marked by calcitonin.
And that brings us to our final thought. Everything we've talked about, the morphology, the nuclear features, it's really just the beginning. The future of pathology, and the answer to a really great follow-up question, is all about connecting what we see under the microscope to the molecular drivers underneath, like BRAF and RAS. Because knowing those mutations doesn't just help us get the diagnosis right, it opens the door for targeted therapies. And that is the bridge from classic pathology to the new era of precision medicine.